Absolutely. We are so honored to have Dr. Zach Foda here with us. He's an MD, PhD, assistant professor of medicine and oncology, and a gastroenterologist who specializes in cancer prevention, and he leads the Johns Hopkins Colon Cancer Risk Assessment Clinic. His area of expertise is familiar adenomatous polyposis and hereditary non-polyposis colorectal cancer or Lynch syndrome. He also focuses on juvenile polyposis, Peutz-Jeghers syndrome, and other such syndromes. He obtained his medical and postdoctorate degrees at the Renaissance School of Medicine at Stony Brook University, and he completed an internal medicine residency at Johns Hopkins and remained there for his fellowship in gastroenterology and hepatology. His current research interests include liquid biopsies, early detection of gastrointestinal cancers, colon cancer risk stratification, and hereditary cancer syndromes. Among his clinical research interests is characterizing cancer risk for patients with multiple polyps and family history of cancer. But I am going to ask you, Dr. Foda, to tell us something interesting about yourself before you kick off your presentation. And I want to thank you again for joining us this afternoon.
Yeah, wonderful. Yeah, thanks for having me. Very happy to be here. Something semi-interesting about myself. While I work in Baltimore, I live in Cecil County with 5 horses, as well as my family and my in-laws. And so people find that interesting sometimes.
Wow.
Great. Yeah, so I think I can just put up my slides and get going here. And so, yes, you should all be seeing that right now. And so I'm going to talk about a few different things, and I have more slides than I probably need, and feel free to cut me off at any point. There are a few sort of natural stopping points, but I just did want to talk about, since colorectal cancer Awareness Month is approaching, and wanted to talk a little bit about that, but also just cancer interception in general. So the title of this talk is Cancer Risk Assessment and Interception, and we'll just touch on some insights from the community, the clinic, and the blood. So just to give an outline of what we'll talk about, some fundamentals of cancer screening. Feel a little bit of embarrassed talking about that with Otis here. Some of these things I could stray from him. And then we'll move on to barriers to CRC screening and a pilot project that we're working on and look to expand. And then if we have time, we'll talk about sort of what I do in clinic every day with risk adapted screening. And then finally, if there's still time and people are interested, we'll talk about what I do in the lab. So as introduced, I'm a gastroenterologist focused on individuals with hereditary cancer syndrome. So those people who are at the highest risk for GI cancers. I'm also a clinical researcher who looks into cancer risk, cancer interception, as well as a basic scientist working on liquid biopsies. And so as you probably all know, sitting in this room, based on sort of how we pulled everybody together, early cancer detection does have, a very great potential for reducing cancer burden in general. It likely has a bigger possibility of reducing burden of death and sort of morbidity than any single treatment or perhaps all treatment combined. However, for screening to work, it must sort of meet a few different criterias. It must find early stage disease, and then you must also be able to do something about this early stage disease that you wouldn't be able to do about later stage disease. And so the sort of fundamentals of things of cancer screening are that the cancer you're screening for must be common in the population. It must have, or preferably will have, a long asymptomatic phase, meaning that you can catch it before the individual shows up to their doctor. If it's symptomatic immediately, then screening, isn't something that's going to be better than just a diagnostic workup. There has to be, as I mentioned, an effective intervention, meaning once you find it early or even a precancerous lesion, you can do something about it that's going to make someone's life better and or longer. And the screening itself has to be safe. So most people who are getting screening, whatever cancer type it is, whether it's breast, colon, prostate, lung, aren't getting any benefit. So therefore, your test must be safe. Must be affordable and cost effective for it to work on a population level. And then it has to be accessible and accepted by the screen eligible population, meaning it's something that people who are at risk should do. And so fortunately, colorectal cancer screening colorectal cancer meets all of these bullet points, with the last one being the last two actually being something that we can always constantly improve. And so just to review some of the epidemiology of colorectal cancer. So every year, nearly 2 million people are diagnosed with nearly 1 million people dying. And that in the US, that's about 150,000 people a year with new cases, with about 50,000 deaths. And that roughly relates to a lifetime prevalence of between 4.5%. And something of note is that the rate of death for individuals younger than 55 has actually increased about 1% per year from 2008 to 2017. And this is part of what we now call the birth cohort effect of colorectal cancer. And so this used to be, or is still, is synonymous with early age onset colorectal cancer. The fact that younger people are getting more colon and other cancers more than they used to. And the concept of birth cohort effect is not that it's not just younger people are getting more cancers. It's that people born in later generations are going to get more cancers throughout their whole lifetime. So meaning that, that the risk of cancer, when you start early, you still continue. And so just to put some fine numbers on it, while most cancers obviously are still are found in people over 50 or older, compared to individuals born between 1950 and 1954, people who are born between 1980 and 1984 are about twice as likely to get CRC. And then those born between 1990 and 1994, about 3 times as likely. And so therefore, there is something going on that is affecting whole generations of people, making the risk of colorectal cancer higher than it was before. And on the right, we haven't figured out the cause yet. It's probably some hand-wavy combination of all of these things that have been put together as the exposome. And it's, but it's something that affects a vast swath of people. So it's likely something in the environment in some sense. And so while that's some of the dire news about colorectal cancer, there is good news. We do know that colon cancer screening works. And colonoscopy or stool-based tests in various studies over the years have shown that you can decrease the incidence anywhere from 10 to 47%, and you can decrease the risk of dying of colorectal cancer from 10 to 68%. I took off this slide for this audience that we haven't shown that colorectal cancer decreases the risk of all-cause mortality, but that is something when I present this to my medical friends, we also sort of do bring up. And so we know colon cancer is a problem. We know colon cancer screening works. So why is it not a problem anymore? And part of that is the colorectal cancer screening is not equally accessed by all. And so these are some maps just pulled up from publicly available data about colorectal cancer screening rates, both throughout the state of Maryland on the left side, and then within the city zip codes within the city of Baltimore. And as you can see on the left side, there are multiple areas where the colorectal cancer screening rate are lower than the certain areas where it's higher. Certain counties have lower maps, as Cecil County. I'm not great with Maryland geography, so I won't guess any of the others. And then on the right side, we see that that there's stark differences even amongst zip codes within Baltimore and the rate of colorectal cancer screening. And so when you have different rates of colorectal cancer screening, you inherently get different rates of colorectal cancer. And as you can see that there are certain regions, Dorchester County, Caroline County, Cecil County, and then in Western Maryland, where you're 10 to greater than 25% above the US rate of colorectal cancer risk, while Howard County, Montgomery County, Frederick County, these ones are below the rates. And so there is some correlation with colorectal cancer screening rates and colorectal cancer outcomes. And so therefore, it is important that even, that we continue to focus on what are the barriers that are specific to these regions that allows that, we can focus on and overcome. And so one of the efforts we've been doing, and this is sort of recent work from this year that we're trying to build up, is a project that working with Allison Klein and others from the Cancer Center is a targeted community-based colorectal cancer screening approach tailored to low uptake communities. And so this is a project that we proposed and have some funding from the Cigarette Restitution Fund, which it is a pilot study looking at CRC screening to target key communities where CRC screening rates are low. And we hope to use this as a launching point to demonstrate our ability as a cancer center to conduct population cancer screening studies. And so the aims of that work were to conduct focus groups in Baltimore City and other Maryland communities to identify barriers that are specific to those communities, and those are barriers and facilitators colorectal cancer screening. And then to see whether or not conducting a pilot study of free stool-based testing in those communities would have a positive impact. And so far, we've conducted 2 focus groups in the past few months in 2 Baltimore housing units. And in those focus groups, we have provided guided discussions of allowing people to share their attitudes on colorectal cancer screening, their knowledge of current screening guidelines, and some perceptions and barriers of the barriers for current screening. And so while we are awaiting more focus groups and haven't progressed yet to sort of have a full qualitative analysis of this, I did just want to share some of the insights, some of the quotes we get from individuals here. And so, these are some questions and some example responses. And so, when we asked, frankly, is screening for colon cancer something that is common where you live? The answer was pretty universally no. While the people in the room said they were aware of it, and most of the people in the room had done it, they said they did not feel that it was a common sight beyond, with their community. One of the barriers, people kept bringing up is that, a lot of men in their housing community don't want to do it. And so people have shared some thoughts on how to make men more open to screening. You can sort of give them the truth, tell them if you don't get screened, this will happen. People brought up the long stigma actually against for health issues in the Black community. And then there are other sort of resources that people are kind of aware of, but they're not fully embraced into. One of the things that people focused on were the barriers for getting screening. And if you look at the barriers, so one is preparation for colonoscopy. 2 is having someone to go with you and bring you back. So that's a ride for colonoscopy. Worried if they find something. So that's less colonoscopy specific, but risks of colonoscopy. So 3 out of these top 5 things are specific to colonoscopy and not specific to colorectal cancer screening. And so that points as an avenue of improving colorectal cancer screening acceptability, if you will. And then some of the stigmas and misconceptions that people mentioned were, the fact that it is an invasive rectal procedure, once again, a colonoscopy. The other one was, once again, harping back to that people, don't want to engage with their medical care. And then another one was, again, about the painfulness of the procedure. Once again, a colonoscopy specific thing. So on balance, a lot of people's hesitations or barriers are barriers to doing a medical procedure, and specifically this semi-invasive medical procedure, not appreciating that there may be other options. And so just to summarize some things that we learned in our first focus groups, there's a stigma surrounding health issues, um, particularly of men of color, um, which makes this a barrier. In the room for the focus groups, there's actually a large preponderance of people with family history of colorectal cancer, and that's why they got screened. They don't perceive screening to be common in their community. And then they stated that it doesn't appear to, but all of these people were actually engaged in their healthcare. They had primary care doctors, and to them, they didn't feel that cancer screening was something that their doctors focused on with them. And whether that's a perception or a reality, it doesn't matter. That's what the patient feels. And so it's just another note and like possibly related to all the burdens that a primary care physician has. And so what will we do next with here? So once we finish this round of focus groups, we will use this as input to sort of make a tailored version of some national educational materials, and then run focus groups on the acceptability, palatability of these materials. And then pending that, we will then sort of the overall sort of part two of this study was to actually engage with community events and provide these educational materials at community events, and then potentially provide non-invasive screening tests at these events to see if we could get people, to engage in their screening. And so, yeah. So that's sort of where this project sits, and we would hope that we're on the lookout for a second sort of community to engage with for these focus groups, and I think that's one of the reasons I was invited here as well, to sort of see what interest there might be there.
Photo, can I just ask you real quick, because I saw that Dorchester and Caroline were one of those later stage counties on the map.
Yeah.
And are you looking for such areas to further this research?
Yeah, I think there would be definitely an opportunity to look in counties on the Eastern Shore, to see what the barriers are. Because while it may be, presumptuous to say that the barriers are going to be different, because, Baltimore City and the rest of Maryland are sort of different places. I would presume there are at least different sorts of barriers, and it would be very important to make sure that those are taken into account, before designing any interventions. And yeah, so we would be interested in expanding.
That's great, Zach. We would be happy. I would be happy to help you get connected to the right locations if you are interested in coming down here.
Great.
And the right people.
Wonderful. That's always helpful. Great. And so, yeah, so I am cognizant of the time. This is like a natural stopping point, but I also have some more I can talk about. I don't know who tells me when to stop, but I'm happy to continue for a little bit longer, or I'm happy to stop and open things up.
I think if you have more information, that would be great. I don't see any questions right now in the chat. I personally was really surprised as to what you were saying in reference to how the frequency of cancer is increasing by those that are born later. I just had no idea that was as significant as it is.
Yeah, I mean, it definitely, the numbers, the way I presented them can sound scarier than they are. I mean, it's still much, much, much more likely after the age of 50 or 55 to be diagnosed with colorectal or any other type of cancer. But there's a noticeable difference then, I think putting it in the framing that if you were born in 1950, or if you're born in 1990, your risk of colorectal cancer is 3 times than what it would be if you were born in 1954. And so that is something that we don't know why it's happening. And also it's something that we can only partially take care of via screening. meaning, the rates below, 40 are so low that screening, it wouldn't meet the criteria for screening all those people. And so another interest of mine, or at least sort of a clinical sort of thing I'm always thinking about, is the diagnostic workup of people who might have early onset colorectal cancer. And that's something that we done. And so I do see a question in the chat about decreasing the testing age. And so the testing age has in fact decreased to 45. I think Otis can take some credit for that. But I think the point is that below, as we get younger and younger, the absolute risk gets low enough that it may not make sense to screen, but it becomes more and more important for physicians and for people to be aware of what symptoms may be associated with an early onset colorectal cancer. And those those are things such as changes in bowel habits, decreased blood counts, abdominal pain, weight loss. And I think it should be a change in practice and not how we screen, but a change in practice and how we practice medicine, and taking those things seriously from patients, and reassuring them that that's most likely not cancer, but making sure that's not. Some data that I saw, this is not directly applicable here, but it's from the UK, that the average number of clinic visits that somebody needed to have before being diagnosed with an early onset cancer was 6. And so people were going through diagnostic odysseys, and it ended up being some cancer. And so I think there are many other ways to help reduce cancer burden than just screening, and that's something that we as physicians always need to do better about. And we also need to makes it us even more important to make sure that individuals are comfortable and have access to not just the screening, but to doctors who can talk about, or providers who can talk about diagnostic testing and that as well. So yeah.
Zach, can I speak to the age of screening people under 45 for a second?
Absolutely.
Yeah, I'm an epidemiologist, and I actually was one of the co-authors of the American Cancer Society's recommendation. There are really 2 issues. One, the number of people who get colorectal cancer under the age of 45 is still very small. So you'd have to screen a lot of people to find a few colon cancers. That is one issue. And unfortunately, since we have a shortage of people who can do colon cancer screening, especially when we talk about colonoscopy, that becomes a huge issue. And remember, colonoscopy also has to be done after a positive FIT test or a positive Cologuard, and we still have a shortage of colonoscopists. Number 2, we need to keep in mind that 80% of the people who develop colon cancer, I believe it's 80%, are over the age of 50. And I can play games, I can play math games that if we went from the 60% of people over 50 getting colon cancer screening to 90%, just increase it, not by 40% to 100%, but increase it by 30% to 90%. The number of lives that we could save from colon cancer are far, far more than the number of lives if we screened all people under the age of 45, and it worked. So I just a plea, let's not forget old folks like me.
So much of this.
I wasn't sure if you mentioned this, but is there a correlation between, like the increase in genetics when it comes to colon cancer?
Yeah. So I can speak to that very well, in that's my focused individual, or one of my focuses. And actually, no, we haven't found a change in that. And so one, yes. So early age onset colorectal cancer is much more likely to happen in people who have a certain genetic condition or certain family history. However, the change in early onset colorectal cancer has nothing to do with the change in genetics. It actually, the same number of people with early onset the same rate of early onset colorectal cancer individuals with a genetic mutation, that rate has remained the same. And so while I'm not saying there isn't a genetic component to it, what I'm saying is that it is some combination of, what I tell my patients, what you're born with and what you've been up to. And you can't change what you're born with. And what people is born with isn't changed at the 40-year time span, but what people are exposed to is. And so that's likely it. What the exposure is, I don't know. Doing that study, what we may never know, or by the time we know, it may have, be an exposure we no longer are exposed to.
So Zach, if you want to take another 10-ish minutes or so, if you want to go through some of your material, I think that would be fine. And we'll continue to monitor the chat.
Yeah, absolutely. So let me talk moving beyond, as I've written here, moving beyond the average risk, the general population, moving to sort of the personalized or precision medicine version of colorectal cancer screening. And so when I see, so this is a lot of what happens when I'm seeing patients in clinic, but this can be done by any provider, any gastroenterologist. And so what is important for right sizing colorectal cancer screening and cancer screening in general is getting an idea of what the risk that someone has of whatever is going to happen to them. And so for individuals when they're coming to my clinic, we're mostly talking about colorectal cancer risk. And the things that we're looking at are family history, and that's family members with the same or similar types of cancer. Personal history for colorectal cancer, people at high risk are those with inflammatory bowel disease. Those are the personal history of polyps. And then there are some other, other conditions that increase the risk of colorectal cancer. And then there's the genetic portion of it. And so that is what, when we look at germline or testing of the genes that people are born with. And so these three pillars are what I'm evaluating for individuals coming to the clinic. And then based on that, we're coming up with a screening plan. And while I would like to say that the screening plan is very precise and such, we don't have the data to say exactly what precision, whether somebody should be getting a colonoscopy in 18 months or 16 months or something like that. We also mostly use round numbers. The part of the reason that we do colonoscopies on average individuals every 10 years because we have 10 fingers. And then when we have higher risk individuals, we cut it in half to 5 fingers. But anyway, the goal eventually is to get to a place where screening is personalized and is having the most sort of bang for your buck. And to sort of visualize this, we can adjust screening based on personal history. And so, for example, an individual in the most simple case of a single relative with colorectal cancer. So in this case, a person's father had colorectal cancer. We say that we know based on the data that it's 1 to 2 times fold lifetime risk of colorectal cancer. So going from 4 per 100 to 7 to 8 per 100. And because of that difference in risk, our recommendations are that individuals with this higher risk actually should only do colonoscopies. They should start 5 years prior to average risk or 10 years prior to the age of diagnosis. And then they should probably do it every 5 years. However, for average risk individuals, we have a sort of menu of different tests that are usable, and we would start at 45. And so if you could imagine this on various different scales and various different sort of levels of detail, every individual coming in should be able to get an individualized screening plan, but that presumes we have enough data on any individual. And one of the ways that we get more data on individuals who have high risk for cancer is through research and through research registries. And so we currently at Johns Hopkins have a research registry called the Hereditary Colorectal Cancer Research Registry, and it's actually been running for now over 50 years. And from this, we've learned a lot about the different genetics of polyposis as well as non-polyposis colon cancer genes, and we currently are still enrolling individuals in this. And then, as I said, the Colorectal Cancer Risk Assessment Clinic is the patient-facing arm of this. And we can, I think, just skip some of the details of this, but I do just want to sort of use this as a plug to say that individuals who should be considered for more screening, and so now we're talking about people getting screening at all. This is now targeting people who may need even more screening, are people whose background, specifically family history, meets something like this. You know, they have multiple family members with the same type of cancer over multiple generations, including individuals at younger age. And so those type of people probably should get more screening and should probably see a specialist to sort of evaluate further and consider genetic testing. And so what genetic testing is we, so the genes are the instructions that make you, you, and we, look at those instructions and look for any misspellings. And based on those misspellings, we can get an idea of whether or not you're at even further increased risk of colorectal cancer or other cancers, rather based on more than just your family history. And the reason we do this is that we know, for example, in Lynch syndrome, people should be getting colonoscopies or their screenings every 1 to 2 years rather than every 5 years or 10 years. And so this makes a big difference. And so this is something that, getting people sort of funneled into this or access to genetic testing, I think can save a lot of lives. And I think, so we have this reduction, we have this risk, we know, we just talked about, who's high or who's low risk. And we talked about screening before and whether colonoscopies, stool tests, and things like that. Screening helps, surveillance helps, that's what we know. But beyond that, diet and lifestyle are two things that we also know are associated with, and I think there was a question in chat about that. So we know that diets high in red meat and processed meat are associated with an increased risk of colorectal cancer. We know that diets high in fiber, high in calcium, high in yogurt seem to be associated with a decreased risk of colorectal cancer. We know that smoking is bad for everything. And then we know that more than one alcoholic drink a day is associated with an increased risk of colorectal cancer. We also know that regular exercise and maintaining an ideal body weight are associated with decreasing the risk of colorectal cancer. And so those are things that everybody can do. And their cardiologist is probably already telling them to do it anyway. So that helps. But, if I tell my patients, if it's good for your heart, it's good for your colon. But people are, they don't put colon healthy stickers on the Cheerios box. So, yeah. And then the last thing here is about blood tests. And so, while colonoscopies are one thing, pooping in a cup is another thing, maybe a world where blood tests for the detection of cancer that work is a world we'll eventually be in. And I will stop there. I do have a few slides on blood tests and work we're doing, but I think I've probably run over.
Just because you have it on your slide, can you comment on chemoprevention?
Yeah, absolutely. So chemoprevention is, just to give a definition, it's giving medications or taking medications that reduce the risk or prevent cancer. And so there are some data to suggest that aspirin in the general population decreases the risk of colorectal cancer. That data isn't strong enough to say that everybody should be taking aspirin. However, in individuals with Lynch syndrome, so one of those high-risk cancer syndromes, there was a randomized trial where they gave half the people 600 milligrams of aspirin and other half the people no aspirin. And the people who had the 600 milligrams of aspirin had a reduced risk of colorectal cancer. Based on that, we, variably recommend aspirin. And so chemoprevention, I think, is a good place that could be useful. The problem is that the financials for developing a chemopreventive drug are hard, and designing a trial for that is hard. Designing a trial for chemotherapy is easy in that people have cancer, and you know that. The problem with designing a chemoprevention trial is that if you're giving somebody a medication with a side effect to prevent something that may or may not happen, then it becomes very difficult. And so I'm not super optimistic that good chemoprevention will exist. But I think it's probably a better opportunity than waiting till it's too late or, over screening people.
Thank you so much. And we really appreciate it.
Yeah.
Any other questions before we move on to our second presenter today? So we have Emily Kiesling, who is from Exact Sciences. She's the market development leader for Exact Sciences, and she's going to do an overview of Cologuard and the screening landscape. I think it's a nice segue from Dr. Foda's talk, where he talked about different options for colorectal screening, but now we're going to focus in on just on Cologuard. So, Emily, feel free to take it away.
Awesome. Thank you. And first, before I share my screen, and hopefully it works, because sometimes, with all the different virtual platforms, just moving all the screens back and forth. So I just wanted to say thank you, Cheryl and Kathy, for allowing us the opportunity to share on this call. I think it's extremely important, especially with March coming up, just to share more awareness of the screening options that are out there. And then also to Dr. Foda, I know you laid a great groundwork. I'm not sure, it's hard to follow something that strong of a presentation with all the data behind it, but it's encouraging to see your the slides that promote all different screening modalities, because in the end, that's what matters, is to get patients screened. So with that said, we normally would have had Jackie Snedeker on the line as well, who you guys were able to meet on the last meeting. She is our senior health equity manager to support a lot of what we're doing within the state of Maryland. But I'm also joined today by Joe Taylor, who is a strategic account manager, supporting a lot of our health systems within the state of Maryland, as well as Jake Hampton, who is our senior director of our healthcare markets, who is supporting all efforts to drive more patients to get screened within our healthcare market. So they might chime in occasionally if a question comes up. And please let me know if somebody says anything. Oh, whoops, I changed did not mean to do that. That's a cool view though. Look, there you go. Hey, Jaleisha, you look good on that, on the little, that view there. Okay. Now that we all got to see who was on camera and who wasn't. All right. Can you see my screen? It's delayed a little bit. Okay, there we go. All right, as Cheryl mentioned, I'm the market development leader with Exact Sciences. I have the honor of working with Maryland in a bunch of different capacities to try to drive more screening. I know on some of our previous calls within the state of Maryland, or Maryland Department of Health, as well as the last meeting for this work group, a big topic that comes up is around the backlog of GIs, or excuse me, colonoscopies, and the lack of access to colonoscopies for some patients. So Cologuard, as Dr. Foda had mentioned, or I guess in his presentation, multi-target stool DNA, I do want to remind you guys throughout this presentation who Cologuard is indicated for. It is indicated for patients 45 and older, male or female, at average risk for colorectal cancer. It is not indicated for patients who have had a positive FIT test in the last year, a positive Cologuard in the last 36 months, or patients that have a higher risk condition such as Crohn's or ulcerative colitis. So keep that in mind as we go through this presentation. If you guys do have questions, please come off mute or put them in the chat, and hopefully we can get you guys an answer. That being said, I do want to address, what Dr. Foda was talking about around the increase of colon cancer is going up, and we're seeing it with even younger patients. So patients 40 to 49 is the leading cause of cancer death in males, and the second most leading cause of cancer death in females. And as you all know, why we're sort of all sitting here today and promoting colon cancer screening throughout the month of March is that it's the most preventable, yet the least prevented form of cancer. So we are really leaning into asking our providers to have these conversations before the age of 45. So that way 45 hits, they are not delaying their screening. And I know Dr. Foda had talked around some of those barriers that exist. It's always interesting for me and my role to learn more of like the different patient demographics and the pockets within different states of the larger barriers. So I know there was one that was talking about, we need to tell the truth. We need to let them know the full capacity of what they're getting themselves into. And we are working with not only the state of Maryland, but across our healthcare market to help drive that conversation and the education around the state of colorectal cancer. That being said, I know we had talked around the backlog of colonoscopies within the Eastern Shore and throughout the state. You guys see it firsthand, whether it be within our FQHCs or health systems, within Johns Hopkins, there is a backlog and we cannot deny that. There's over 60 million patients that are due for screening yesterday and even more today. And there's around 15,000 practicing GIs with an average 4,000 patient backlog per GI. So we cannot rely solely on Dr. Foda and his peers to screen these patients alone. We need to offer options up front and be truthful, to that statement from those patients that within that housing group. We want to make sure that we are sharing the full truth and the options that exist for patients to get screened. And in a study that showed only 38% of patients actually followed through with that colonoscopy referral when they were offered that screening modality. So just some data points to think through as we try to change that behavior of our providers or have those conversations with patients, and leaning into Cologuard as an option for your average risk patient population. And what that looks like, I'm going to first dive into Cologuard, right? So Cologuard and Exact Sciences, we've been around for over 10 years. We celebrated the birthday not too long ago of Cologuard being available to your patients and your providers for over 10 years. We remain dedicated to being innovative in the space of bringing you guys the best test that's out there with backing of great clinical data. That being said, with Cologuard, the overall sensitivity for stages 1 through 4 is 92%. And the sensitivity for stages 1 and 2, which I think we might have touched on that previous presentation, where patients have very little to no symptoms. So those are the patients that are coming in, they keep on denying, they feel like they don't need to be screened. Those are those patients at 94% sensitivity for stages 1 and 2. That's when we need to get them screened. The chances of survivability drastically increases at stages 1 and 2 versus 3 and 4. Specificity overall for Cologuard is 87%, and with a clean colonoscopy, 90%. So for you all, as far as like reliable results, I think this is what I know myself that we speak a lot around as the screening test is the goal is to rule out cancer. That is the goal of a screening test. And where you guys can feel confident in educating your community, educating your providers, educating your staff is that Cologuard has a strong negative predictive value at 99.9%, which means if a patient had a negative test result, there was a 99.9% chance that they did not have colorectal cancer. So it gives that sense of assurance in having those conversations with your patients when they do receive a negative, that it's a true negative. And before I pivot into the next thing and the big thing that maybe Dr. Foda and Dr. Otis Brawley also have been able to maybe research or been a part of some of the recent webinars. Like I said, Exact Sciences is committed to bringing you guys the best test that's out there for patients and for your average risk patients and being non-invasive. And that being said, Cologuard Plus is something that I'm extremely excited to be able to share with you all and the state of Maryland that will soon be available to patients and without changing a workflow for a single provider. This is just hard work and dedication. I wish I could take any credit, but I can't, of our team at Exact Sciences to drive a better test to market. And what the overall sensitivity showed was stages 1 through 4 at 95% and specificity at 94%. So we are completely committed to not only overcoming some of those barriers that Dr. Foda mentioned, but bringing a more clinically sound test to your providers, to your community, so that patients feel even more reassured that they are getting tested with something great that's out there. And when we speak around the reliable results, so I know I spoke about the Cologuard test that's currently available and on market, but the Cologuard Plus test has an increase in the negative predictive value at 99.98% negative predictive value, which again just gives that confidence for providers to educate back to the patients when they receive a negative test result. One thing that I would like to touch on as well is the adherence, right? So we talk about the adherence to colonoscopy all the time within our provider one-on-one education, and then even within health systems. But as the data point mentioned earlier, only 38% of patients actually adhere to that screening colonoscopy. But in a separate study that was done, 71% of eligible patients adhere to the Cologuard test. What I'd like to just highlight within this slide is providing options and providing the full awareness of what patients can expect for their screening that they're choosing will hopefully increase that overall adherence to actually completing the test. And we want to get more of those patients screened. And again, we cannot rely solely on the GIs within our community to get the job done. We need to lean in more to our primary care, our OBGYNs, and anywhere else where we can have those screening conversations to drive 71% even higher. All right. And when we talk about support, I think this is something easy I could talk to with my eyes closed. Because it is a screening test, Cologuard and Cologuard Plus, it is covered under the Affordable Care Act. So for Cologuard, over 96% of patients have no out-of-pocket cost. We are working diligently across the state of Maryland and within our entire healthcare market to make sure all patients, regardless of insurance, have access to Cologuard. So just feel confident in knowing that should you have a patient that is eligible for Cologuard, that there should be very little to no cost at all for the patient to complete the kit. Another point that I would like to highlight, I know we talked about barriers from the previous presentation. We also recognize that there are many barriers to get patients screened. One piece to Cologuard, it's not just that it's a great clinical test with great data behind it, but there is a whole patient navigation program and a component to the test. So every single patient that is ordered Cologuard, whether it be from their provider, their health department, their payer, what have you, every single patient is entered into our patient navigation program. And what that does is it follows the patient throughout the life of the order and the duration of their screening journey. And we are doing gentle reminders to try to get them to complete their kit. We are educating them on the urgency to get screened, and we are letting them know that we are there for them 24/7 should they have any questions. This is a huge piece and where we've seen success because we're supporting them along their journey, where it can be, to some of those points earlier, there could be a fear component. There could be the guy down the street was just diagnosed stage 4 and is given a certain amount of time to live. So we are following them along their journey, hand in hand, to make sure that they're returning that kit and completing their screening. All right. Now, in summary, before we start opening it up and have any questions, our ask, and I know Sharmisa, I saw her on the line earlier. We are constantly in conversations with the state of Maryland, our health systems, our individual providers, working closely with our GIs to try to bridge the gap, to try to close the gap for CRC by offering Cologuard first for your average risk patients. We have an abundance of resources available to not only your providers, but to patients, to specific communities, to address some of those barriers that might feel very niche to you, but we have resources that are available to overcome some of those fears that those patients have. So in summary, Cologuard is a great option for your average risk patient population, reserving those higher risk patients for your colonoscopies to drive down that 60 million patients that are due for screening today. And with a sensitivity very comparable to colonoscopy and the high adherence that we see with Cologuard, upwards of 70%, you all can feel confident knowing that you guys have that broad coverage of Cologuard throughout the state of Maryland to get those patients screened. So I'm going to pause there because that was a lot of just me talking. And with Joe and Jake on the line, they probably are laughing because they're like, Emily loves to talk. But I'd love to hear from y'all's perspective. What are you seeing? What are you hearing? Dr. Foda, I might bring you in on this conversation to get your perspective on, just some of the feedback around using Cologuard as an option for patients to get screened.
Emily, could I ask you to take your slides down so we could have a
Yes.
conversation and see each other? Thank you.
Mm-hmm. There we go.
I can jump in here actually just to start with a question, and then I can give some comments on that. But this is something that patients ask me, and I think I hand waved it to the right answer sometimes. But for a positive Cologuard, what is the likelihood I'm going to find a cancer in there? Do you have a number that is in your book that I can safely say rather than hand waving some calculations there?
You know what? If anybody were going to ask me that question, it was going to be you. So thank you for the question. What I can say is, so what you're referring to is like false positives, false negatives, right?
So it'd be a false negative, but false negative for CRC rather than
Correct.
false negative for
Right.
it. Sorry, not false negative. Sorry. What is the true positive rate?
Yes. So what I can say though is around the false negatives and false positives that they do occur. I just compliantly have to say that. So
Sure.
for Cologuard Plus, out of 100,000 patients, around 2 patients will be falsely reassured that they will have CRC. And so that's a low rate.
They will not.
But they will not,
Yeah.
right? So if
Yeah.
they received a negative, but they did not. Yeah.
So,
I'll also,
yeah.
oh, I'm sorry. I'll just also comment to Emily's point. Dr. Foote, if you're asking for the positive predictive value,
No, just the true positive rate out of 100. So I think, based on I usually quote 4% of people that I'm going to scope with a positive Cologuard are going to have colorectal cancer. I don't know where I got that number, but I think that's yeah. I was just wondering if with Cologuard, yes.
You are fairly 3.%. 3.2% will have a colorectal cancer.
So
Yeah,
again,
right.
you have to reassure your patients and community members that
Yeah,
yes, it is
exactly.
one of the screening tests that's going to then buy you a colonoscopy, but it doesn't mean it's an automatic cancer. Is that the point that you're making? But it
Exactly. That's why I wanted to bring that up,
Yeah.
is that I tell the patients it's some number there. Like a lot of patients will roll in, get to the colonoscopy and be having a heart attack because they're like, I have cancer, this positive test. And I think that's just something that, yes, screening is important, and these, we're not going to miss many cancers with the non-invasive screening, but a positive non-invasive test isn't the end of the world. And so that's something that needs to be shared with people. Yeah.
So Susan Bolden has a question. How can I get multiple test kits for my church members? They are older and do not use the internet, but I'd really like to get them the test and make it available to them.
I love that.
You can talk about how that distribution occurs.
Yes. Well, first, I also wanted to just touch on that Dr. Foda comment around sharing that information. I think you are 1,000% right. Writing a note down. I think that comes down to that barrier of we just need to know the full truth. So that falls on to us at Exact Sciences to educate the full scope of what does a negative mean, what does a positive mean, and then educating that appropriately back to the patient. So thank you. All right. So I saw the comment around the church members. Yes. So I think that's, again, another thing that do not use the internet. So Cologuard is prescription based. If you do, and Sophia, forgive me, I don't know what community you serve or what organization you work with.
I
Cheryl.
think she's in Easton. She's
Okay.
in Easton.
Feel free. I'll put my email in the chat, or Cheryl, you can provide that. I know we try to contain emails, but I'm happy to share my information. We can try to figure out how we can get those church members access to Cologuard.
I mean,
And
right
then-
now, we're encouraging people to go to their FQHCs, their primary care doctors. And if anyone is on the call, I think I saw Shane Asselone actually asking a question that, have you used Cologuard yet for distribution in the FQHCs on the Eastern Shore? Does anybody have experience with that?
No, Sarah was on.
Yes. Hi. So yes, we are working very closely with Emily and Jackie right now to get enrolled in a patient assistance program to make sure that our patients, all of our patients, are able to get Cologuard. So we're excited for that partnership.
Hi, this is Shane. We've just started working with our FQHC to get the Cologuard orders. I actually got my first result in on one of my first patients just the other day. There's a few kinks, but we're working it out as far as flow, and I anticipate within a few weeks everything will be situated, and maybe I can start going at a more rapid pace of getting more Cologuards completed, because I certainly have a list of people to do.
And yeah, thanks for sharing that, Shane. I'd be happy to connect a little bit more if there is like some kinks. What I can say is we try to work through those, whether we're talking about patient barriers, but we also talk about provider barriers, organization barriers. So there's a variety of ways that we can help just streamline those things. So happy to help. And I'll put my email in the chat if you guys need support there.
And Taylor Jones, yeah, is Cheryl, you were just about to mention, she has this great question, which I'm really actually excited to hear. Like, how do we help to share the message in our community? Because this is such an exciting time to be able to help people save lives,
I agree. I think this can be a tag team approach with Dr. Foda too. So he's probably loving me asking him to come off mute here every second. But I think this is a great question too, because this is showing that you all within that a different department of where we would think we would have our education around colorectal cancer, you guys are seeing the need that we need to spread it beyond our primary care, beyond our GIs. So it's really it's up to you all how you want to spread the awareness. From Exact Sciences perspective, we have a bunch of resources to help guide those conversations, or just simply to guide a patient to understanding the modalities that are out there. But from Dr. Foda's perspective, I'm curious to see what his thoughts are.
Yeah, I mean, I think as many touch points as possible is very important. I don't want to sort of undervalue the role of a primary care physician, because as I sort of hinted to, we can prevent all the colon cancer we want, but people will die of heart attacks. And so, part of the messaging should be that this is part of your overall preventive screening. And if your primary care doctor is too busy dealing with your blood pressure, diabetes, just, you should be aware that you should be, when they talk about it, you don't need a 25-minute conversation. You know about it because your pharmacist told you about it, or you have the materials. They're just the ones facilitating it for you as part of it, right? Colonoscopy, colon cancer screening is sometimes, has a little more effort to it than getting somebody's cholesterol or ordering a statin. And so I think it's, sort of an extra touch point rather than sort of replacing the need for a primary care doctor.
But I found that statistic, Emily, that you shared earlier about how many people follow through when they're asked to do a colorectal screening in comparison to a Cologuard. I just feel like if 71% are going to do the Cologuard and only 38% are going to do the colorectal screening. If we could just convince a few more primary care providers not to say that it's the only option out there. Like my personal primary care provider said, I don't want you to have a Cologuard. I want you to have the colonoscopy. So but if I didn't have a little extra money in the bank, I would not have done the screening at all because they wouldn't have prescribed me the Cologuard. They would have said, this is the only option for you. So I think that there's also some communication that has to be given to the primary care providers to say 71% of your patients are going to get this test. I don't think they all know that. And I would love to be a part of that, sharing that message too.
Yeah.
Yeah,
Yeah, I think,
absolutely.
yeah, go ahead, Dr. Foda. Go ahead.
No, I mean, I think, yes, that is a lapse in a primary care doctor's sort of knowledge of what's going on. And that just, maybe exists. Obviously, your primary care doctor may know about your risk differently and things like that. And so I don't want to speak specifically about anybody's patient care, but if a primary care doctor is only offering colonoscopy to individuals at average risk, then that is not consistent with any of our national guidelines and is not consistent with modern medical practice. And so, yes, I think, I guess I'm just presuming that people will stay up to date, but.
And Dr.
I guess
Burley, do
that
you want to
makes sense.
follow up?
Yeah.
I thought I saw a hand there waving.
Oh, I actually, I put it in the talk. I was just thinking, what about fit testing? The U.S. Preventive Services Task Force says that appropriate screening is stool blood testing looking for hemoglobin with FIT done every year, stool DNA testing, which the only one on the market right now is Cologuard, done every 3 years, or colonoscopy in normal risk individuals done every 10 years. And I think all three of them are very reasonable. And we've actually never proven that one is better than the other. Indeed, the colonoscopy, which everybody thinks of as the gold standard, was proven effective in a study to assess stool blood testing with FIT, in which people had a positive FIT won a colonoscopy. So I would look at all of those things. FIT testing is much cheaper, but you have to do it every year compared to Cologuard or to colonoscopy. And then Cologuard and FIT testing have the disadvantage that if you have a positive test, you do need to get a colonoscopy. I live in a world where the entire United States are my patients, and we have parts of Maryland, we have large parts of the United States. They're called Idaho, Montana, North and South Dakota, that don't have very many GI docs who can do colonoscopy. And a lot of people out there can't afford the $300 or $400 for a Cologuard test. So I would love to see all of those things used. And as I said earlier, 40% of adults over the age of 50 get no colorectal cancer screening whatsoever. And the number of lives that we could positively affect if we could get into that group of people is tremendous.
I think you bring up a great point. So thank you for calling out the other modality that was not highlighted. Obviously, we're speaking at Exact Sciences about Cologuard. But what I can say is working very closely with a lot of our FQHCs, we will never eliminate all modalities, and we don't want to, because then we're doing the opposite of what we're trying to do, which is to drive screening and get more patients screened. So there is a need for all modalities, but when it comes to the screening intervals, I also want to say thank you there, because you highlighted the 3-year interval for Cologuard versus one with FIT, and then I know the 10-year for colonoscopy. So the one thing that I will say is yes, there is the right option for patient, but back to Dr. Foda's point too, of just laying all the information out there. I think that's where the missing piece is when we're speaking directly with our providers. I know Exact Sciences, we can do a better job of educating our providers of all options, but then we also need them to relay that back to the patients, because ultimately it's the conversation between the provider and patient that's going to be decided on what screening modality is best.
Yeah, let me just tell you a very short, interesting story. One of my medical school classmates who has an unrepressed Sister Mary Joseph gene runs a FQHC in Pontiac, Michigan, or I should say unrepressed Mother Teresa gene. He runs a federally qualified health system in Pontiac, Michigan. His FQHC is given by the federal government, by HRSA, 30 colonoscopies per month. That's all. They can use those 30 colonoscopies for people who are having GI bleeds. They can use them for screening for colonoscopy. They get 30 a month. Well, he thought, well, I want to do some colorectal cancer screening. If I do stool blood testing, which is cheap, it's $30 a test, I can screen a lot of people with stool blood testing. And then the ones who have a positive stool blood test, we will use one of those 30 colonoscopies per month on them. He thought this was a great idea. I initially thought it was a great idea. And then everybody in his community started protesting that the rich people get colonoscopy and we get this stool blood testing thing. And it was a really interesting lesson about social. It was an interesting social message, I should say, that the people were not interested in stool blood testing. And by the way, remember I told you earlier, the science to tell us that Cologuard and colonoscopy saves lives is based on a clinical trial that told us that stool blood testing saves lives. But everybody wants the new technology.
So I think, the best test is the one that the patient will do. And that's the one,
Well
that's the
said.
bottom line message that we always have to say.
Well
Because
said.
again, I elected not to do colonoscopy and do stool-based tests. Of course, it was during COVID and that was what it was accessible. But then again, depending on your risk, you just have to make sure that that message is loud and clear. I think we are over time, so I will turn it over to our Chair Kathy to find out if you want to, at least for the presentations over time, if you want to elicit any conversation among the community in terms of next steps or what they're planning for colorectal cancer awareness months or anything else.
I think that's great. Thank you guys for your presentations. This was wonderful. I mean, some wonderful general information and specific information. I just really appreciate it. And Cheryl, thank you for being able to offer, the context for Emily in case we do have additional questions in the future about how we can, get the message out even more. I notice we have a few people here from the health department. And if I don't think everyone on this call actually knows, Shane, what's going on in our health departments and what you're doing to help the community be able to get the Cologuard test. Would you be willing to speak a little bit about that?
Hi guys, yeah, sure. So right now I actually had a waiting list for people that of average risk. They were vetted to make sure they were of average risk. Um, that we were waiting for the partnership with Cologuard, which is established now. So now I'm starting to go down that list, and I'm continuing to take referrals from the FQHCs and vetting them. The waiting list was 80 plus people, and like I said, I can continue to have referrals trickle in um, and vet them. Right now, our situation is we have locally in Salisbury, where I'm at, which is kind of the seat of my county. I have one full-time provider doing colonoscopies in my county. Um, as far as neighboring counties, there's a few there. Some of them have tremendous waiting lists themselves, as does my provider in Salisbury. So I know that Tidal Health, I'm confident they're trying to recruit help. But that's kind of our situation. And I'm very happy for the partnership with Cologuard to help these clients get no cost Cologuard screenings. And then if they're positive, of course, we're going to arrange somehow for them to get this colonoscopy that they will need. So that's the situation.
Well, thank you for sharing that, Shane. Is anyone else here from the health department on the call that would like to share anything?
Oh, yeah. Hi, this is Sharmista from the Maryland Department of Health statewide. So just to say, like, we have this statewide effort for Cologuard access for the uninsured. So I guess let me kind of explain something. Cologuard is trying to establish their relationships with FQHCs all over the state so that the FQHCs can also themselves order Cologuard regardless of insurance status, right? If you have insurance, insurance will be billed. If you're uninsured, the FQHCs can also help them get access to cost Cologuard. For those who like patients that get services from non-FQHCs, like, you know, private practice or whatever, and they're not automatically like pre-screened for income or whatever, they can get routed through the health department, and the health department will then, you know, vet them for the no cost Cologuard. So we're really trying to make sure that no one can be denied Cologuard in the state. And so, like, if you're uninsured, we'll hook you up, especially if you're low income, we'll hook you up, you know, so either through the FQHC directly or through the local health department.
And if finances are concerned, the FIT test sounds like it's a wonderful opportunity for a lot of people who might be in the in between, not sure what to do next. Should people just talk to their primary care providers and say, I would like to do the FIT test just to make sure I'm okay? If they're in the right age range is what I'm thinking. Okay.
The other question, if I can ask, is what programs exist to get people who have a positive FIT or a positive Cologuard, the colonoscopy? It would be a shame that someone is walking around with a positive test in need of a colonoscopy and can't get it.
So it's the same for uninsured or underinsured, it's the same state program, like our cigarette restitution fund. So we've been around for 20 years to provide cancer screenings for people who are uninsured or underinsured. But our issue was the backlog of getting people to colonoscopy. So we were like, okay, if we can route people, the average risk to Cologuard or FIT, that can alleviate the backlog. But we're not taking away colonoscopy access for uninsured. It's still there.
Okay, great. In planning for next month, what's happening in our community? Does anyone have anything that they're doing to kind of bring awareness to the importance of colorectal screening that they'd like to share?
There. So what I've got down so far is I've actually connected with a nurse who helps disseminate through a church, a local church, to help disseminate newsletters with colorectal cancer awareness information. And these newsletters this newsletter also includes our local health department's contact information for my program. She also disseminates educational materials to about 75 churches on colorectal cancer. So I've been in touch with her. And so, you know, we have that going on. Of course, Go Blue Day, we always do our Go Blue Day advertisements, and we put out a lot of stuff on Facebook. And then here at my job, of course, we wear blue, and we set up all kinds of displays here. Also, like local businesses, if they want us to come speak or set up a table, we do that. Right now, I'm scheduled to go to Purdue corporate around the mid-month. We're also locally here in Wycomico County connected with the new Haitian Creole Development Center. We were actually going to see them this week, but it's being moved to March. So that'll be something that'll be really good. I mean, that particular population we've been trying to reach, and that development center looks great. I've been in there. And then also, not until it's going to fall in April, but there's an event at the local community college where we're going to do some education. So that's kind of what we have going on right now.
That's great, Shane. That's wonderful. I'm glad to hear it. Sounds like some really great activities for our community. Let me know if I can help you in any way. Emily, if you have a one pager that there's really hot statistics that you shared, that would be really helpful to have in-house, that we can kind of get the message out when we go to our community fairs, which we're actually having our Health Fest on March 15th here in the community. So if anybody is interested in attending something like that, we'd love to have you. You can reach out to me and I can give you more information on how to attend that. Do we have any last minute questions? We're closing up time.
And I just want to make a comment, Kathy, about
Yeah, sure.
Zach's and his presentation. He is looking for help among this group, community CAG members, to find individuals who may want to participate in his focus group. And so I already saw Sarah Worm put in the chat, thank you, that you would help with that. But, oh, I can see you now, Zach. But do you want to talk a little bit about what that looks like, the time commitment, and that the participants would actually get a small reimbursement for participating in this?
Yeah, just, yeah, one minute on it. So it's the focus groups are about an hour and a half, and we give out gift cards with them, and then we just sort of talk about colorectal cancer screening and things like that. And we'd be looking to plan these over the coming months, and we have some paperwork to do to get sites out there, but yeah, so if that's, we could get more firm details to share, but if that's something that, people in the community that you interact with may be interested in, that's something that we would love help with.
Sarah Worm, would you tell me where you're from? Would you mind coming off mute?
Yes, Chop Tank Community Health. We serve Caroline, Talbot, Dorchester, Kent, and Queen Anne's County on the Eastern Shore.
Great. We had a representative, Rochelle. She's also from University of Maryland. She's in Dorchester County as well. So maybe sometime we'll be able to get right into that area that you're most in need of, kind of talking with those people who have the highest frequency of death due to
It's
nothing.
okay. I think I have a follow-up call with Rochelle in the next week or two. Maybe
Yeah.
I'll loop in Kathy and Sarah and Rochelle, and we'll try and work out some of the details of this, because I was impressed with that map that
Yeah.
Zach showed, and how there are counties that we can definitely impact in the Eastern Shore.
That's great.
And Kathy,
Thank you.
one more thing.
Yeah.
I'm sorry. Before we all go, in the chat, I dropped a link for our survey for tonight's talk. If you guys can please fill out the survey, it is live and we'll resend it out with a recording as well if you are unable to fill it out in this time. But your responses really do help us and help guide how we move our CAGs in the future. So please fill that out if you have a moment.
And we did have one more request to potentially move this meeting just a half an hour earlier, if possible, starting it at 3 so that we can end the day at 4:30. I'm not sure if we put that in the Jaleesa, if we put that actually in the survey or not, but if anybody, we can try it for next month at 3 o'clock and see how it goes. Would anybody that's currently planning on coming to the next one have a protest to actually participate at 3 o'clock? See a few shaking head no. So maybe we'll try that, Cheryl. We'll see if that works.
And let's put also ideas for speakers for next month. Please put that in the survey, because we will, work through that again. Some of us work behind the scenes a little bit to plan for speakers for next month. Ellen, how are you?
Hi, I'm good. Thank you. I'm sorry I was late. I do have a spot scheduled with Diakonia, which is one of our homeless programs in West Ocean City. And the topic was going to be lifelong poison safety, but since it's colorectal cancer month, I'm sure they would be open to changing that. However, I do not have a canned presentation. And if there's somebody on the call that would like to partner with me and show up in person, and I say in person because they do not have the technology to do Zoom meetings. So if there's anybody on the call that would feel comfortable, it's primarily adults, men and women. They're currently in diakonia, or they've, have a history of being homeless and lots of health problems around, poverty health problems. So if anybody's interested, I'm going to put my contact information in the chat box, and I'd be happy to pony up with somebody and do that.
So Ellen, we do have, CHEs, and we do have a colorectal cancer presentation. So let's connect offline. Okay?
Okay.
Definitely connect
Sure.
offline.
Thank you again, everyone. It's 5 o'clock now. I really appreciate you joining us. Oh, I can't wait to see you again next month. And we're gonna just keep learning as we grow. So thank you.
And thank you, Emily and Dr. Foda.
Yes, thank you.
Fantastic.
Thank you, Dr. Foden.
Thanks, Zach. Thanks, Emily.
Thank you.